Today we'll be discussing what the heck is NEC, necrotizing enterocolitis. My name is Aspen Wall. I'm the NICU clinical pharmacist at the Children's Hospital of San Antonio. Our objectives today are to define necrotizing enterocolitis and spontaneous intestinal perforation. We'll review the incidence and pathophysiology of NEC, identify risk factors for the development, and examine prevention techniques and treatment options for NEC. We'll describe some of the inconsistencies in the use of probiotics for prevention of NEC and discuss some patient cases. I have some abbreviations here for you to refer to throughout the presentation. There are a couple of NEC-like disease states that can make the diagnosis of NEC difficult. Recent literature has tried to distinguish classic NEC from spontaneous intestinal perforation, or SIP. Necrotizing enterocolitis is a multifactorial inflammatory condition. We'll get a little bit more into that pathophysiology in a minute. Its onset is inversely proportional to your gestational age, so the more preterm you are, the later your risk of NEC developing. It's associated with some progressive changes in imaging, and it may be related to your enteral feed status. On the other hand, SIP, or spontaneous intestinal perforation, typically occurs early, like within the first day of life. It is not associated with feeds. It's spontaneous, so there's no progressive imaging changes, and it has a non-ischemic pathology. SIP has been found to be associated with the use of indomethacin, like for prevention of IVH, and early steroid use. NEC is one of the most common disease states in neonates. It is associated with significant morbidity and mortality. There's always lots of research identifying risk factors, trying to reduce overall rates. In the last 50 years, however, the rates have been pretty steady due to the improved lower gestational age survival. Typically, infants with NEC remain hospitalized about 60 days longer than infants who did not develop NEC. And bowel resection is a major cause of short bowel syndrome in pediatrics and is associated with significant healthcare costs, about $1.5 million for a 5-year period. You can see the healthcare cost of necrotizing enterocolitis just in the US is very significant. This graph demonstrates the relationship between gestational age and age of diagnosis. Along the x-axis are the gestational age cohorts, and the age at diagnosis is on the y-axis. The blue line is overlaid to show the inverse relationship between gestational age and onset of NEC. The age at diagnosis of NEC decreases as gestational age increases. For example, a patient born at 23 weeks gestation has the highest incidence at 30 days of life, versus a 31-week infant is most at risk in the first 10 days. On the other side of this is spontaneous intestinal perforation. So the red line outlines the incidence of SIP, which, as you can see, may occur in the first few days of life pretty consistently, no matter what your gestational age is. I'm going to go through a brief discussion of the pathophysiology of NEC as it is currently understood. As mentioned earlier, NEC is a multifactorial condition, and we'll get into each one of these factors and explore how they all contribute to the potential development of NEC. As described earlier, prematurity alone is a risk factor for the development. Infants born at less than 32 weeks gestation are considered to be at the highest risk. I always say when you're born prematurely, everything is premature, including your GI tract. So you have slow gut motility while the GI tract tries to figure out what it's supposed to be doing. You also have aberrant vascular regulation, which leads to weak, tight junctions, which means there's holes in the intestinal wall. And these holes can allow the passage of bacteria that shouldn't be there. We'll have a picture of this later for visual learners. Again, premature everything means you also have a premature immune system. neonates have an increased expression of toll-like receptor 4, which is a pro-inflammatory factor. Toll-like receptor 4 gradually increases in expression with increasing gestational age until term, when its expression is downregulated. In the preterm neonate, the unbalanced expression of this inflammatory factor can have detrimental effects when activated due to increased apoptosis and decreased enterocyte proliferation, which further weakens the intestinal lining integrity. Genetic factors have been implicated in affecting outcomes or severity of NEC. That is seen in some studies with data for mono and dizygotic twins, which leads to the potential value in exploring genetic association. The early use of broad-spectrum antibiotics can reduce the diversity and growth of the intestinal microbiome, which has been shown to adversely affect the intestinal immune system and increase the risk of NEC. This is a visual representation of the pathophysiology we just discussed, demonstrating the effect of the leaky cellular junctions that can increase the risk of bacterial translocation and ultimately lead to intestinal necrosis. Just like the previously discussed pathophysiology, there are multiple risk factors that have been found to be linked to NEC. Potential genetic anomalies, chorioamnionitis, or an infection of the membrane surrounding the fetus in utero, intestinal immaturity, and changes in the vascular tone are all considered prenatal risk factors for the development of NEC. The stress of a preterm delivery and low gestational age, low birth weight are also associated risk factors with the development of NEC, along with abnormal microbial colonization. Neonatal care factors, these are more like the risk factors that we introduce to our patients, so environmental stressors, providing respiratory support, the type of feeding the patient is receiving, and then pharmacologic interventions such as H2 blockers, indomethacin, steroids have all been associated with increasing the risk of developing NEC. There are long-term outcomes associated with development of NEC. Patients with medical or surgical NEC are at increased risk for GI abnormalities, for example, our short gut patients post-bowel resection, neurologic deficits, cerebral palsy, visual, cognitive, and psychomotor impairments, all related to ischemic insults or nutritional deficits. Clinical diagnosis is based on physical exam combined with laboratory and radiographic findings. You may be examining your patient and find that they have abdominal distension or tenderness, or a baby that was tolerating feeds well now isn't tolerating feeds and has had multiple episodes of emesis, or increased gastric residuals if you are at a facility that measures gastric residuals. You may have multiple reports of apnea and bradycardia episodes, along with temperature instability. On laboratory findings, you might see a metabolic acidosis or a leukopenia or leukocytosis with increasing bands. Radiographic findings, you might see an intestinal dilation or fixed loop dilated bowel or pneumoperitoneum. All of these things will be combined to tell you that your patient may be developing NEC. Classic radiographic findings leading to diagnosis of NEC are pneumatosis intestinalis, the presence of gas within the wall of the intestine, which can be seen in figure B in the lower arrow, dilated loops of bowel, again shown in this figure B, and the upper arrow points to portal venous air, so that's air here up in the liver. If the imaging showed a paucity of gas, that would be a gasless abdomen, which indicates bowel ischemia, and on an x-ray, it would be, your abdominal x-ray would be mostly white. Other exam findings, such as abdominal distension and discoloration, seen in Figure A, and systemic hypotension may lead you to the diagnosis of NEC. Figure C shows an area of necrotic bowel in a surgical patient with necrotizing enterocolitis. The Bell's criteria for classification was introduced in 1978. These criteria serve as a method to classify the severity of NEC and to guide intervention options. There has been a recent shift to just 3 stages, so medical NEC stage 1 and 2 versus surgical NEC stage 3, but you will find the modified Bell staging we're going to discuss here in the majority of literature currently. When trying to classify NEC and guide your treatment plan, it's helpful to approach based on the signs and symptoms you have available. Systemic, abdominal, and radiographic. If you don't have the answer to one of those questions, then find it. If the nurse reports emesis and blood in the stool, along with increased apneic and bradycardia spells, it's probably a good idea to get an x-ray and look at the abdomen along with your physical exam. NEC can progress quickly from suspected to severe, so serial monitoring is very important. For stage 1, A and B suspected NEC, the usual treatment plan is to make the patient NPO. You will likely start empiric antibiotics while you wait for cultures and allow the abdomen to decompress. In stage 2, A and B, systemic signs are now showing up in labs with metabolic acidosis, thrombocytopenia. In addition to emesis and bloody stools, you may now have no bowel sounds, and you may or may not have tenderness and cellulitis on your abdominal exam. On x-ray, there may be some more intestinal dilation and pneumatosis, and that's the air in the wall of the intestine. Patients at this stage typically need to be NPO for 7 to 10 days for stage 2A or mildly ill versus 14 days for moderate, with empiric antibiotics for both groups during that time. We'll discuss our antimicrobial choices shortly. And again, patients will need serial monitoring, x-rays, labs to ensure they're not progressing to a stage that may require surgical intervention. It's probably a good idea if you identify your patient at this stage to notify your surgery team so they can be aware of a potential surgical intervention. At stage 3, you can see that your symptoms have progressed to typical septic symptoms: acidosis, hypotension, potentially DIC, neutropenia, everything pointing to the fact that your patient is very sick. For classification purposes, you can see the biggest difference between stage 3A and B is the perforated bowel. Bowel perforation definitely requires surgical intervention in addition to medical support. If a bowel perforation cannot be confirmed on x-ray, but the patient is demonstrating all other signs, it would be very beneficial to have the surgical team involved at that time. Keep in mind, progression from these stages 1, 2, and 3 can happen almost instantly, it seems, very quickly for your patient. So that's why the serial monitoring is very important. Taking a closer look at the treatment options, medical management is the best approach for stage 1 and 2, meaning bowel rest, empiric antibiotics, and always close monitoring and serial labs for progression. Surgical management, as we discussed previously, you might want to make sure your surgery team's aware of a patient that's identified as stage 2. They definitely would be involved in stage 3. In regards to surgical management, there's some discussions in the literature about placing peritoneal drains versus exploratory laparotomies. There's still a lot to tease out about which may be best. Patients with drain placement may still progress to require a laparotomy and potential resection, but not all. So trying to identify which patients benefit from drain placement versus an XLAP. And all the patients will, of course, still have bowel rest and empiric antibiotics. Okay, so here's the big question, right? Which antibiotics do we use? The choice really varies based on the antibiogram at your facility, provider preference, and the need for anaerobic coverage. Keeping in mind the majority of patients that develop NEC are patients that have been in a NICU. So when you're thinking about empiric coverage, you need to think about all those nosocomial bugs, especially gram-negatives like your E. coli and Klebsiella. It's not as common to have gram-positive bacteria causing NEC, but it's not impossible. So you may want to include gram-positive coverage in your empiric therapy. Very often patients will be started on a combination of gram-positive and negative, plus or minus anaerobic coverage, and then we can peel those layers away as the clinical picture changes. In general, if surgical intervention is required, patients definitely receive broad-spectrum antimicrobials, including anaerobes. So as I mentioned, your empiric choice is often based on your unit-specific organism resistance pattern, so your antibiogram. The literature has a lot of opinions on which antimicrobial combination may be best, but there is not a true guideline for therapy. So there is variation at facility to facility based on provider preference and experience, in addition to the specific unit experiences. At my hospital, we often treat with single agent piperacillin tazobactam. If the patient clinically worsens, the antimicrobial choice can of course be modified. We try to reserve carbapenems for patients with known susceptibilities that require carbapenem, or if they're clinically worsening on pip/tazo or the cefepime flagyl combination. Cefepime is the alternative to cefotaxime, which may not be available to you depending on where you practice. So cefotaxime is no longer manufactured in the United States, but some areas of the country have the ability to get it from Canada, so they may still have that option. So we've discussed the risk factors, diagnosis, and some treatment options for NEC, but how can we prevent it? This is where the literature really explodes. There are so many studies that look at NEC as an outcome with so many great ideas and lots of potential, but often they're proved and disproved over and over again. So what do we know? We know that enteral feeding is good for you. It can be scary to think about feeding your 23-week infant, but in the long run, early exposure to colostrum and express breast milk or donor breast milk is very beneficial. We know that just having a standardized feeding protocol and following it, of course, reduces the risk of NEC. Every facility may have their own protocol, but the evidence supports that just by having one, no consensus of what that protocol might be, but just having one, your risk for development of NEC is reduced. You want to promote healthy gut flora. Maybe you want to use probiotics to seed the gut with good bacteria. Definitely environmental protection, right? Keeping the unit clean, good aseptic technique with central lines, and of course, always washing your hands. And we want to limit broad-spectrum antimicrobial use. This one can be tricky when you have a preterm baby in an ICU setting. The possibilities for infection seem endless, but narrowing therapy and limiting rule-outs to 48 hours or 36 hours can be very beneficial. And this is where, as pharmacists, we get to shine. So promoting antimicrobial stewardship is all of our jobs. And of course, that's a whole other presentation. So getting into a little bit about probiotics. So there's benefits and risks back and forth throughout the literature. Some probiotics have been found to decrease intestinal permeability by affecting that toll-like receptor 4 pathway that we discussed previously, and decreasing your interleukin and tissue necrosis factor expression. On the downside, there's limited data as to which bacterial strain is best. So typically we recommend something with bifidobacterium, which is found in breast milk, but other ideal strains remain unclear. Again, there may be some mediation of the TLR4 response, so we have potentially less apoptosis of intestinal enterocytes. There are currently no FDA-approved products for use in neonates, and unfortunately, that lack of oversight can often lead to variable purity, and you can find a lot of case reports in the literature discussing contamination of these products. In addition, with the potential for contamination, there can be variability within the strains in a single product of the number of strains, the number of bacteria. So most of the literature has shown that multi-strain and high colony forming units is necessary to see that benefit at NEC prevention. And within any product, you might have a lot of variation, so that can make your choice difficult. So as I mentioned, again, multi-strain products are associated with the best outcomes. There's lots of studies to read about the use of probiotics and the risks and benefits. A lot of them have small number of patients and may not really be powered to show their. So as you can see, the risk benefit back and forth for use of probiotic is pretty variable, and so that leads to some inconsistency in prescribing practice or use of these products, mostly coming down to provider experiences and what your particular unit wants to do. So there's no true consensus on which species to use, although it is recommended to have a product with bifidobacterium that's found in breast milk. There's no regulation by the FDA of these products' production, so you have to take that with you when you're recommending these products, the potential risks for contamination and the conflicting evidence of benefits. But in general, if you are recommending probiotics, it's useful to, again, have high colony forming units and maybe a combination of these bacteria, bifidobacterium, lactobacillus, and lactococcus. So getting into our cases, baby boy W is a former 24-week gestational age infant, now 31 weeks corrected. The patient was transitioned to full enteral feeds at 28 weeks. When rounding today, the night shift nurse reported the patient had emesis following 2 feedings overnight and several bradycardia desaturation episodes requiring stimulation for recovery. The resident reports abdominal distension on exam. So what would most likely be your next steps? A, call surgery to bedside stat. B, make the patient NPO and start probiotics. C, make the patient NPO, order an abdominal x-ray, BMP, and cultures. D, initiate broad-spectrum antibiotics. So your best option would be to make your patient NPO, order your abdominal x-ray, BMP, and cultures. Again, it's that serial monitoring and keeping a close eye on your patients to make sure that they're not going to progress. You very likely would start broad-spectrum antibiotics after you obtain your cultures, and you would definitely make them NPO at the time, but maybe not starting probiotics at this time if you're making your patient NPO. And it might be useful to consult surgery so they're aware of the potential patient, but they don't need to be called to the bedside stat. So the same patient, the lab work is complete and the CBC shows a decreased platelet count and your ABG is there. Your x-ray is suspicious for portal venous gas. So what stage of NEC would this likely be classified as? A, suspected, stage 1A. B, stage 2B, definite or moderately ill, or C, stage 3A, advanced severely ill. So this patient would be classified as stage 2B. They progressed to definite, and they're showing thrombocytopenia, the portovenous gas, and metabolic acidosis. So our second case, baby L, is an 800-gram, 25-week gestational age infant, now 2 days old. The patient is NPO on full TPN, a dopamine drip at 10 mics per kilo per minute, and IV hydrocortisone 1 milligram per kilo per dose every 8 hours. Baby L has completed 2 doses of a 3-dose course of indomethacin for IVH prevention. This morning's X-ray is concerning for pneumoperitoneum. Based on baby L's age and risk factors, what is the likely diagnosis? A. Stage 3A NEC, B. Hirschsprung's disease, or C. SIP, spontaneous intestinal perforation. Based on baby L's age and risk factors, the likely diagnosis is spontaneous intestinal perforation, most likely associated with co-administration of indomethacin and hydrocortisone, along with the lower gestational age and the fact that he's only 2 days old. For our third case, baby boy F is a former 30-week gestational age infant, now 6 days old. Over the weekend, a sepsis screening was initiated. Based on exam and imaging, the patient is being treated for presumed stage 2B NEC. Blood cultures were drawn and the baby was empirically started on vancomycin, piperacillin tazobactam, and gentamicin. 48 hours of empiric therapy has been completed as of Monday morning. Upon reviewing the patient profile, the following is identified. Your patient is MRSA screened negative. The blood cultures are negative. Your CBC is improving and CRP is downtrending. However, serum creatinine has increased to 1 milligram per deciliter. Which are possible interventions that could be made based on this patient's current status? A. Continue empiric 3-drug regimen for a total of 10 days. B. Stop all 3 agents and place the patient on meropenem for a total of 10 days. Or C. Discontinue vancomycin and gentamicin and complete 10 days total of piperacillin tazobactam. Based on the fact that your patient had a negative MRSA screen, you can likely discontinue vancomycin. You likely do not need meropenem at this point because your patient is clinically improving, and it could be unnecessary to broaden to a carbapenem based on the information that we have available from this case. So the best choice would be to discontinue vancomycin and gentamicin and complete 10 days of piperacillin tazobactam. So 14 days later, your baby has completed treatment for medical NEC and is back on increasing enteral feeds. The resident on rounds asks you about starting probiotics in this patient. So which option would be the most appropriate? A, absolutely not, no probiotics ever. B, probiotics may have some benefit in prevention of NEC. If initiated, you want to use a combination product with multiple strains. C, it's important to discuss risk and benefit with providers and families to decide on the best option for the patient. Or D, both B and C. So there may be a place for probiotics in practice. We just may not have all fully appreciated where that place is at this point. So there could be some potential benefit in prevention of NEC. You do want to use a combination product if you are going to use probiotics. And you definitely want to discuss with providers and families to decide the best option for your patient. So a combination of those two answers. B and C would be the best choice. So just a quick recap over what we have discussed. Preterm infants are at high risk for NEC based on many factors. Again, genetic, perinatal factors, and other factors that we introduce to them just by treating a preterm infant. The best thing is early identification and intervention, so serial monitoring of your patients and keeping a close eye on them. Making appropriate antimicrobial choices can be tricky, but you want to do your best based on your unit-specific information. And prevention is ideal, but we don't know exactly what the best approach for prevention is. So probiotic use, yes or no, that may vary based on where you practice.